All right. Hello, and welcome to today's Wound Care Learning webinar. This presentation is entitled A Breakthrough in the Management of Difficult to Heal Diabetic Foot Ulcer, an innovative film-forming wound dressing, StrataGRT, StrataMed, from Stratpharma, Switzerland. My name is Curtis Bensel, Director of Customer Relations and Operations for Stratpharma US. And I want to thank everybody for joining us this Friday. We'd also like to thank HMP Global for sponsoring this presentation with us. During the webinar, feel free to submit questions, comments to our speakers by using the question submission section on your screen. At the end of the presentations, we'll try to answer as many of your questions as we can in the time allotted. We're very pleased to welcome our featured speakers, Dr. Shanna Frazier and Dr. Jamila Banks. Dr. Frazier has been registered nurse for 29 years. She completed her undergraduate degree at Dominican University in San Rafael, California. And for the past 19 years, she's worked as a certified wound, ostomy, and nurse in various settings. She completed her master's degree in nursing at Incarnate Word University in San Antonio, Texas in 2013, and her PhD at the University of Texas Health and Science Center in San Antonio in 2020. Her degree in nursing research, her background in wound care, led her to Stratpharma here, where she currently serves as our medical science liaison. She's been with Stratpharma since their US launch in June of 2021. We also have joining us today, Dr. Banks, who is a board certified and fellowship trained foot and ankle surgeon with her extensive training in diabetic limb salvage and advanced wound care, medical author and lecturer. She completed her pediatric medicine degree at Temple University School of Pediatric Medicine in Philadelphia, PA. While in Philadelphia, she worked at the Gate Lab studying foot and ankle pathologies and assisted in developing athletic tennis shoes for StrataGRT for kids. The next years, a 7-year surgical and research fellowship at the Carl T. Hayden Phoenix VA Medical Center, where she became expert in all aspects of foot and ankle surgery. She is currently perfecting her skills at the University of Texas Southwestern Medical Center, Department of Plastic Surgery, where she's performed over 1,000, she's treated over 1,000 patients in 1 year. So welcome to both of you, and thank you for joining us today. We're happy to have you. And first, we're going to turn it over to Dr. Shanna Frazier, followed by Dr. Banks, and then our Q&A.
So we all know that wounds are a challenge to treat. They can require an abundance of resources. They can certainly cause a risk for infection that might lead to sepsis and even death in some cases. And overall, they decrease the quality of life of a patient that is dealing with them. 9 million people are living with chronic wounds in the US at the current time. And it is estimated that 25% of diabetics will eventually experience a foot ulcer, and $50 million is the amount of that is impacts on healthcare. So we do have some current treatment and challenges. So if we're still considering that we use a considerable amount of topical antibiotics, and this leads to antibiotic resistance and often poor outcomes. If we're thinking about systemic antibiotics, we are also prescribing those in astronomical numbers these days. We know that these antibiotics don't always work. They are often cumbersome in that they require long-term therapy. They can also be very expensive, and 20% of patients experience adverse drug events from using these systemic antibiotics. So continuing with some current challenges, We know that wounds are traditionally covered with physical bandages and that this leads to difficulty in monitoring the wound. This might lead to an increased infection if you can't see what's going on. If the patients are at home, they may not be looking at the wound themselves. And then also the cost of these dressings astronomical, estimated at over $9,000 to treat a wound in the U.S. currently.
Hello, my name is Eduardo Serrano. I am the Chief Scientific Officer with Stratpharma, based in the headquarters in Switzerland. So we're just experiencing a little bit of trouble with internet connection of my colleague, Dr. Frazier. So I'm going to just continue the presentation until we figure out what happened. So we left just when we were about to start the conversation about StrataGRT. So allow me to continue. Okay, very good. So the indications of StrataGRT are various and very extended. So obviously for the presentation today, we're going to be focusing mainly around the indications for chronic wounds, and mentioning these, we obviously can use StrataGRT in venous insufficiency ulcers, in arterial or ischemic ulcers, also neuropathic or diabetic ulcers, and of course also pressure or decubitus ulcers. We will be looking at some of the clinical data and some of the pictures that we've been collecting over the years, which is going to be obviously very interesting. The product can also be used for acute wounds. So obviously of any kind, it could be a post-traumatic injury, a burn, skin of tear, a wound dehiscence, or immediately after surgery. When we mean immediately after surgery, it would be an application on top of the suture line before we even apply the secondary dressing. So when we're talking about StrataGRT, it's always an immediate application upon we have the issue on the skin, whatever that might be, okay? Good, so why is StrataGRT an innovative product? Okay, what are we bringing new to the market, and what is the innovation that is presented here today? So probably the most important factor is the first one that we see listed here. So the product is a film-forming, flexible, full contact gel. Okay, when you see the product, if you've had the chance to see it with your own eyes and use it with your own hands, you'll see that the product comes in a box and inside in a tube, right? So this can be applied in any type of issue, and it's going to dry and form a film over the surface of the wound. This is very important for the mode of action. It's going to stay on the surface, in contrast with any other topical product that we may be used to use in other indications. StrataGRT is able to stay on the surface, okay? And that is the benefit to the product. Once the film is on site, it's going to have certain benefits. The first one, and most important, is obviously a faster wound healing. We will also be able to protect the area. This film is acting as a wound dressing itself. It's a primary wound dressing, so we will have a protection from the outer environment, any type of reactive that might be trying to have an issue with our patients, but also from the inside, let's say, because the product is bacteriostatic as well. So if we do have a clean surgery, or if we don't have an infection present, as soon as we start using StrataGRT, we will prevent an infection from happening, okay? The product is also going to be providing hydration to the area and allows gas permeability. It is a semi-permeable membrane at the end of the day, okay? So it will be allowing breathability, which is important. We need oxygenation for wounds to heal, and we're not going to macerate those wounds. So again, the key factors of a semi-permeable membrane. It is compatible with secondary dressings. So some of the cases that we will see, it is recommended to use a secondary dressing just to protect the StrataGRT layer. However, it is not necessary, but it is compatible with any type of secondary dressing. It is obviously good, well indicated for hard to treat areas, especially areas where anatomical complications, for example, skin folds or areas with joints and mobility, because it is a gel and it is flexible and it will dry and adapt and resurface any anatomical complexity. It is very well indicated for areas that are hard to cover with a normal physical dressing. It is non-reactive, meaning that it's completely biocompatible with human biology, so we can use it at no risk to the patient. So far, we have not reported adverse events with the use of StrataGRT. And of course, easy to use. As we said, it's a gel in a tube, so even patients could apply this at home without further training. Obviously, depends on the size of the injury and the location of the injury. We will recommend nursing intervention depending on the case, right? Very good. So the clinical benefits of StrataGRT, we summarize here before we look at the clinical data. So we're able to, through the semi-permeable membrane that is going to dry over the wound, we will have, I see that someone is missing me. So I can finish this slide and then we can continue with Dr. Fraser, if that is okay. Yeah? Good. So the film is going to provide permeability, so reducing the transepidermal water loss, and this extra hydration to the wound, preventing maceration, is going to improve, most importantly, keratinocyte migration. Okay, so this is what we see in our clinical data. The wounds that are treated with StrataGRT, we can see this very clearly in clinically, but also in basic science that we've done some studies as well. We see even as fast as 24 hours upon application of StrataGRT versus control that the keratinocytes are able to migrate at a much faster pace. Okay, so this is obviously because we are providing a good environment for this to happen. The other benefit, as we said, is suitable for different wound types and shapes. The excellent flexibility of the product will allow it to dry on different areas, and it mimics an epidermal barrier at the end of the day, which is an important factor. And just to summarize again, simple, easy to use, convenient to use, painless upon application. It's not necessary to be removed. Important. We will look at that at the end with how to use. And it's chemically and mechanically compatible with secondary dressings, and patients could continue to apply the product at home. And here we see on the blue box here at the bottom, the product, the way it's designed, it's a very big polymeric network, even if it's a gel. This will not allow the product to be absorbed through the wound. And that is the reason why it will stay on the surface of the wounds and allow the purpose and the clinical benefit to actually happen. And I'm going to stop now to allow Dr. Fraser to continue.
Thank you. I apologize about that. I am in San Antonio and we are experiencing a storm right now. So let's get right back to StrataGRT and how it works. So if you look at the schematic on the left, let's pretend that it's any wound. And on the right, we have applied our thin layer of StrataGRT. So you can see that we are trapping the perfect amount of exudate with this wound. So it's going to continue to allow for those moist healing wound properties that we need. And then also the schematic picture on the right shows you that the wound will continue to be able to breathe as long as the StrataGRT is on there. And this layer is very thin. So once you've applied the product, I do usually use the example that the size of an apple seed will cover the back of your hand. Once it is dry in that 5 to 6 minute times, it is not something that you can peel away like a Tegaderm. So it's much thinner than that. So how does it work? It keeps that perfect amount of exudate there. We know that the exudate has the nutrients for the epithelial cells. Besides providing that moist wound environment, that it also contains the electrolytes, the leukocytes, and the fibrinogen and fibrin that is necessary for wound healing. This is just another schematic picture that shows how the product is semi-occlusive. It does allow for the vapor to pass through. So in comparison to a product that is petrolatum-based, which might trap the moisture and cause an inflammatory response in the skin. So this, when you apply the StrataGRT, essentially you are providing a temporary layer of emergency skin that will serve to protect the skin. So we do, here at Stratpharma, love our pictures. We do have some phenomenal examples. These pictures were taken from Dr. Benedetto's practice. He's an established dermatologist. that has published for us in Philadelphia. And you can see that the treatment and the success of treating this wound on the scalp, which are difficult to treat wounds using StrataGRT, and that only after 1 week of therapy using the gel twice a day, the improvement that in this picture. So this picture is again another scalp wound. It's you can see that we have exposed bone. So when you're using StrataGRT, there is no contraindication for exposed bone or tendon. In general, you do need to have a clean wound. So post-debridement, partial thickness to full thickness wounds are appropriate. We just in general say to stay away from a deep tunneling wound. And you can see in this picture again on a wound that's on the scalp, difficult to heal, that after 6 weeks, we've been able to successfully heal this wound. Again, another scalp wound that is from Dr. Benedetto's practice, and you can see the success there in these pictures. Dr. Benedetto, I did mention that he had conducted some research for us. So this is a study that looked at the comparison of triple antibiotic ointment. We know that that often causes contact dermatitis. So in this study, you looked at 334 patients. StrataGRT was compared to triple antibiotic directly, and 21.6% of the patients that used the triple antibiotic ointment did have contact dermatitis, and the patients that used StrataGRT did not experience any contact dermatitis. This is an example of a Mohs surgery patient, also from Dr. Benedetto's practice. You can see that the 66-year-old patient, so again, you know, the older patients that sometimes have trouble healing wounds, and the success after weeks of treating with StrataGRT. So this is another study that was done with StrataGRT. This study was a burn study, so it had an interesting design in that the patient was their own control. So by that, I just mean that the wound, the burn actually was divided in half and treated with StrataGRT on one half, and then also the control on the other half of the wound. The products that were used were standard of care, included silver products, so silver alginates, and then also Silvadene. And you can see that StrataMed, which is the same as StrataGRT, epithelialized the wound in 5.4 days versus the control group of 12.5 days. So again, this is just some case series that with venous ulcers, you can see by the end of a month that we were able to heal those wounds using StrataGRT. Again, these are just a few more examples of some lower extremity vascular ulcers and after, again, within that in that month period that the wounds were closed. This top example is a diabetic foot ulcer. You can see after 1 month that we've made considerable improvement with the GRT. And the wound on the bottom, again, just a reminder that, you know, of course, the wound had to be debrided. So this product does not have anything additional for debridement, although it will assist the body with autolytic debridement, that after using this product, after 6 months, that the wound on the scalp is resolved. So one of my favorite things about StrataGRT is that it can be used with a dressing or without. Without a dressing, it is a twice-a-day application. It's a very thin layer. I do use that example of the apple seed size covering the back of your hand. It does take the 5 to 6 minute dry time. And the wins that I hear from the field without a dressing are heel fissures, those interdigital spaces, so the in between the toes or the fingers, and really any area that it's difficult to dress or may have hair where the dressing won't stay. So maybe a stage 2 pressure injury would be appropriate to use StrataGRT and in any other area of the body, as it is safe to use on all areas of the body. This can also be used with a dressing. And so if you are using StrataGRT with a dressing, it does become a whole different ballgame. And by that, I just mean that it does not have to have that 5 to 6 minute dry time. You can apply the product a little bit more generously. You can cover it with your dressing of choice. And so by that, I mean, if you are a clinic that is more, operates more on the economical side and you use a lot of gauze dressings, certainly this dressing can stay on for a day if you're using the gauze dressing. If you're lucky enough to have those fancy foam dressings, then you could apply the StrataGRT and leave it for up to 7 days. It is bacteriostatic, so it's going to be perfect to use beneath a total contact cast or even a compression wrap, and you should feel comfortable leaving that since it is bacteriostatic. So it can be applied in the clinic, probably with a Q-tip or a gloved finger. At home, we just generally instruct that a clean finger is fine, and that again, you could cover with your dressing of choice. I will say that you may need to reapply if you're using it without a dressing in the area that has continuous washing, that you may need to reapply the product, and an additional application is going to be fine. You do not need to remove StrataGRT, and you could continue to cleanse the wound with your normal protocol. So that would be your normal saline, your commercial cleanser, whether it is surfactant-based or antimicrobial in nature. Any of those are going to be fine to continue to clean the wound with. It is available in a 20-gram tube. So that is enough to treat a 6 by 12 centimeter area twice a day for 60 days. And some additional information that you might need to be aware of. It is only contraindicated in persons with a silicone allergy. We do know that that is rare since silicone is in lots of products today, even used as preservatives in our food products. We have not had any adverse events with any of our suite of silicone products here at Stratpharma. So there are no known drug interactions, and it can be used all over the body. So any area of the body is safe, any age is safe, and even in the perineal region, this product works amazing because we all know that that's a difficult area to treat. So just in summary, to remind you that StrataGRT is an amazing silicone gel product. It's easy to use. It can be used on any type of wound post-debridement. And we hope that you will give it a try, and we look forward to hearing your experiences. Thank you. And so now the webinar will continue with Dr. Banks.
Okay, thank you for the introduction and that wonderful presentation by Dr. Fraser and Eduardo. My talk or my portion today will actually be the fun part of the talk because we get to see lots of pictures. But these are basically just my personal cases. I'll focus mainly on chronic diabetic foot ulcers. Dr. Fraser did a wonderful job with addressing the challenges and treatments of chronic wounds. So I won't really go through this slide in detail. We all know it's a big problem. I want to start by talking about chronic wounds and diabetic foot ulcers. It's really important to basically know what the diagnosis is of your non-healing wound. Is it venous? Is it diabetic? And as a podiatrist, obviously I see a lot of diabetic patients, a lot of foot ulcers, and just knowing what the etiology is makes a big difference. More than 85% of amputations that are in the lower extremity starts just like this picture on the top in diabetic patients. A lot of these patients also have neuropathy. this is a major contributing factor, along when their foot is deformed, when there's callus, trauma, when they have vascular insufficiency. All those things play a role in treating these patients. So really, the basic tenets of wound assessment becomes really important. So a thorough assessment, like I mentioned, is going to help us guide treatment. A systematic approach is also needed. Diabetes, of course, this has to be controlled. As my next few slides, most of the patients that are taken to the hospital that I operate on, their diabetes is out of control. Most of the time, this needs to be improved in order to control their hyperglycemia, because you will see that when that's controlled, everything kind of falls in line. Their wound starts looking better. But when it's not, then this is when we see the patients have really bad outcomes. Vascular assessment, this is also important. Many of our diabetic patients have a component of vascular insufficiency. In the beginning, don't hesitate to refer them to a vascular surgeon or get vascular interventions for arterial imaging, angiography, duplex scanning, possibly revascularization in order to heal these non-healing wounds. The goal is to obviously restore a palpable pulse in the affected foot where they have a wound. In contrast, you also need to address venous insufficiency with compression wraps. Infection control is also really, really important. If your wound healing fails, you always have to check that the infection is not part of it. Excessive bioburden, this can inhibit normal progression of wound healing. Acutely infected wounds, those are pretty easy to diagnose. But sometimes when I mentioned neuropathy, they can usually mask the presence of deep infection, an abscess. In our diabetic patients, they can't really feel, so you can't tell how bad or how severe the infection is. But the suspicion for infection should always remain high, especially in our insensate patients. So once we see that they're infected, they need to be treated aggressively, and this means thorough debridement of their abscess, debridement of the infected bone, following this with antimicrobial therapy and even surgery to make sure the infection is eradicated. Time principles, which I'll talk about in the next slide. This acronym refers to tissue assessment and management, which we'll focus on. Debridement, I can't stress enough. Ways to debride a wound, you can use scalpel, curettes, tissue nipper. Now there's different hydrosurgical or ultrasonic debridement kits we could use. Sharp debridement is important. You have to remove all the non-viable tissue and slough, remove all the biofilm to ensure that we have a good granular base. Offloading, in the same way, I can't stress enough, when this component in wound care is neglected, successful outcomes are pretty low. So whether it be, offloading boots, a total contact cast, especially for plantar wounds, this is really important to give to our patients. And like I mentioned, VLUs, compressive therapy is really important. And I just want to make a note that you have to pay attention to mixed arterial and venous disease as well. Time principle. This was summarized by Leeper nicely. It's been used over the last decade or so to facilitate an organized approach to wound bed prep. And again, it's tissue management. Make sure the inflammation and the infection is controlled well. It's important to have moisture imbalance management, so that always has to be balanced. And then the edge of wound observation and management is important. The time principles, I can't stress enough. This incorporates the basic tenets of wound care that we just discussed. So now for some cases, this is a 38-year-old type 1 diabetic male. The first picture here actually is his second debridement. As you can see, when he first came in the emergency room, his glucose was over 600. Like most of my male patients, they wait to go see a doctor. His wife noticed this as a blister and encouraged this patient to go in to a doctor, but he hesitated. By the time we got to him, he had fevers, he was septic, his white count was over 12. Again, his glucose was uncontrolled and he was not alert and oriented. So we took him to the operating room. This looks like a pretty aggressive wound. I wish I put the first picture. When he first came, he had pus, but all the skin was intact. In my training, it's super important to make sure all the dead tissue is removed. I think one of the problems that are a common mistake, not enough aggressive debridement is required. But when you don't see this beefy red granular tissue and you still see slough, you still smell the tissue, all that usually have to be removed. So basically, I took him to the operating room 2 times. This first picture is after his second debridement and after VAC therapy. I used wound vac for about 4 weeks. I also use an amniotic graft to get him to, to this 3rd or 4th picture. I believe I applied almost 10 grafts. I was seeing the patient every week. He was offloaded. Again, we got endocrinology involved. He was seen in the wound center every week. We were changing his dressing. At this point, once the wound was more superficial, we started using StrataGRT, and we got him to about this 4th picture and 5th picture. And, he's doing really, really well. And at this rate, I don't imagine that he will have any issues if he stays controlled and if he continues to keep his diabetes, his nutrition under control. So this is one example. My next example is one of my favorite patients. Let me move to our next slide here. What's going on? Oh, okay. So this is one of my patients. Again, like any of our patients that come in, you see the first picture there. One leg is a lot more erythematous. The left lower extremity is swollen compared to the right. You see all these blisters that's really showing on the dorsal foot. When I took him to the operating room, we made an incision between the 4th and 5th toes and purulent drainage. I think we got about 20 cc's of purulent draining, tracking along the extensor digitorum longus tendon to the proximal part of his ankle. So we opened this up really well. I just kind of wanted to show you the extent. We didn't use StrataGRT until this second picture here, but it's important to be able to have a big options for our patients, just because, these are limb salvage procedures when we do these. And, they can come with really tiny wounds, but they can get complicated pretty easily. So when I started using Strata, and this case for this patient is actually what made me a believer to use it, because I've used hydrogel, I've used iodosorb, I've offloaded him, I've taken him to the operating room, we've debrided him. This second picture is, I want to say, about a year and 3 months post all of those things. And this patient stayed at this 1.5 centimeter squared wound, and it just was not healing. I have and I routinely debride the patient. He sees me every week in clinic. And I throw my hands, I don't know what else to use. I've used grafts, I use amniotic fish skin, I've used, umbilical cord, different things, but his wound just stayed resistant. When I got a hold of StrataGRT, we started applying it. I said, what's the worst that can happen? I've already tried all kinds of things, and I know this patient is really high risk. So, when we want to try to heal these patients as quickly as possible to ensure they don't get reinfected. I've consulted vascular surgery. I've done everything on my book as a checklist, but this patient just wasn't healing. When I used StrataGRT and how we did it, we just applied a small amount. We did it every week. I think my suggestion for him, every dressing change, and at this point he was changing it, I want to say 3 times a week, and he would apply a thin amount. He also had a home care nurse helping him with this. We slowly saw improvement. So it started to epithelialize the wounds on the outside. I started seeing it get smaller and smaller. And again, we had to continue him offloading. I had to continue him debridement to make sure that we're getting rid of all that callus. Because as we mentioned earlier, offloading is really important, because I tell my patients, this is like a paper cut. No matter what grafts or what we use for your wound, it's not going to heal if you're just constantly picking at the wound. And that's how challenging some of these plantar wounds are. In short, we used it, I believe the third picture, and I'm sorry, I do not have my timelines. The third picture was about 2 weeks after. I think we were taking pictures every 2 weeks. And this patient eventually healed just by switching to StrataGRT. Okay, here is another example. This patient had a lateral 5th metatarsal wound. He came in with cellulitis. This was also a post-incision and drainage patient. We also used negative pressure a little bit, as well as a small amniotic graft. Once we got him to the second picture where he epithelialized well, that's when I used StrataGRT, and about 4 weeks he healed after that. I believe this is my last foot picture. This was a lateral foot wound. The patient was also taken for an IND of his wound. We used a fish graft on the first, on the first picture here. This was post-graft application. I started using StrataGRT at the second picture on every week. The patient was applying it every dressing change. I think we kept him at 3 times a week dressing change. And for these patients, we were putting a little Adaptic and just an island dressing, and he healed as well pretty beautifully. I wanted to show you this last slide before we wrap up. This is my split thickness skin graft harvest site on the thigh. So sometimes when there's leftover graft and the wound is completely covered, I would apply some of the skin back to the harvest site. And as you see, it granulated really nice. And most of the time, thigh harvest sites do not have a problem healing, but I also use StrataGRT once the graft incorporated, and we got really, really good results. I think this patient healed within 2 to 3 weeks. So in conclusion, the field of wound care is expanding every day with advances in technology. While there's no superior substitute for, the time management, making sure that debridement, proper offloading, all those things we talked about, those are all important, but there's not one wound product that's superior over the other. If somebody tells you that they just use iodosorb or Aquacel, my suspicion is really, it makes me pretty suspicious because not every patient will fit that category. But as I presented here, a lot of our patients are really difficult to heal. They're high-risk patients. So any new product, wound vacs, grafts product, my threshold basically for using new products and, advanced therapies is pretty low for these patients. And again, there's constant effort in adapting different materials for chronic wounds. And sometimes as a practitioner, you get inundated with, what do I use? There's so many things on the market. Furthermore, there's a lack of evidence that supports any single method. So I think that, Dr. Frazier did a great job discussing silicone and StrataGRT, its indications. But in my cases that I shown today, they were pretty effective in treating chronic wounds when other products, could not. Again, as I mentioned, in conclusion, the basic tenets of wound care, we need to routinely follow those. We need to evaluate the patients to see what the appropriate wound care is for them. It's important to understand their underlying pathology and identifying what is causing failures for their wounds to heal. But in these cases, silicone gel just increases our options for treatment. And with that, I have my email here, and I believe we will go in our questions and answer format. If you guys have any questions, we're happy to answer them for you.
All right. Thank you, Dr. Frazier and Dr. Banks, and of course, Eduardo, for jumping in there. Thanks, everybody, for being patient during our technical interruption, but glad that everyone's still hanging in. So right now, we'd like to open up the discussion to the audience. Throughout the speaking presentation, we've had some questions sent over. And if there is any other questions that maybe we don't get to, please send them along because we can also follow up directly. So we'll try to get to as many as possible here. So the first question that we'd like to get to, Dr. Banks, just kind of following up, I think, on that last section there, which secondary dressing would you recommend using over StrataGRT?
Well, when I use the StrataGRT, I think most of my wounds were already pretty close to epithelialization, and they've not really deep anymore. So what I routinely did, so it doesn't kind of, get soaked up in the gauze, I would put a little Adaptic, secure it with steri strips, and then put 4x4 Kerlix and Ace. Now, when the wounds were on the toes or, they're pretty superficial, I would just put like an island dressing immediately to cover it. And it doesn't take very long to pretty much dry on the wound. What I didn't want to do is basically put it and then some of the dressing gets swept away by your dressings. That's, it's a waste of the product. And I think I was pretty clear on making sure that the patients understood that. But, anytime we use products like iodosorb, I kind of don't really put anything else but my dressing.
Okay, perfect. And just kind of following up on that, Shanna, one of the questions is, can I use StrataGRT on wounds that are exudating?
Yes, you can. So the beauty of this product, like I mentioned, is with the dressing or without. So for example, my son had his toenail removed a couple of weeks ago. And, that can be oozy, messy in the beginning. So we applied StrataGRT on the wound. I did cut a small piece of alginate, just regular alginate, because the silver alginate is not necessary since StrataGRT is bacteriostatic. So covered the alginate with a Band-Aid, and that was the dressing that he used for the first couple of days. I think that you'll see that the silicone is going to calm that inflammatory process quickly, and the drainage will stop sooner. And so then after just a couple of days, he was able to use StrataGRT until the wound closed. So absolutely, you can add an alginate or maybe even something a little bit more aggressive like a Drawtex type product if needed.
Somebody else had followed up here, and this is actually kind of a perfect follow-up, Dr. Frazier. So what is the application time to dressing change?
So like I mentioned, if you're a clinic that uses gauze and you usually change gauze daily, then StrataGRT with a gauze dressing, I would recommend daily change. The beauty about the product is really it can meet you with wherever you need to be. So by that, I mean, if you're working with home health, and you have that twice a week or 3 times a week limitation with the home nurse visits, then StrataGRT can meet you at the 2 or 3 times a week. If you're using one of those fancy foam dressings, or like I mentioned, if you have a total contact cast or compression wrap, you can apply the StrataGRT and then put your total contact cast or your compression wrap over it and leave it for up to 7 days. And you should feel comfortable doing so because remember, the product is bacteriostatic. I will mention that if you apply the product to the peri wound, that it is going to provide you some protection like a skin protectant product would. And so I would make that recommendation. And then just remember, if you do have drainage, to add something additional for absorption.
Fantastic. Another question here. Does StrataGRT have any anti-infective ingredients? How does it prevent infection? And I think we'll send this one over to Eduardo Serrano.
Thank you, Curtis. Very interesting question. So StrataGRT does have antimicrobial efficacy. However, it does not achieve such purpose with pharmacological action. So it does, to answer the question briefly, it does not contain an active ingredient as the ones we're used to see in devices sometimes, like silver dressings or other type of molecules that could have pharmacological effects on bacteria or yeast as well. And in this case, the antimicrobial efficacy or the bacteriostatic effect of StrataGRT is simply achieved by the nature of the raw materials that we're using. Remember that when we apply StrataGRT, it's going to dry and form a film over those wounds that we are treating. And this dressing is not going to allow bacteria to replicate and to continue growing. So it's basically going to keep the area, preventing that effect from happening. To make sure that this is also correct, we've done all the testing, the corresponding testing following the US Pharmacopoeia, following the antimicrobial efficacy lab testing to ensure that we can, of course, make these claims. So yeah, that would be the answer.
Fantastic. And back to Dr. Banks, what is amniotic graft?
So amniotic graft is, there's different products now on the market, thousands of them. They are basically harvested during C-sections. And I'm sorry if you guys can hear my background noise, but basically it has a lot of growth factors. To summarize, it has a lot of growth factors that help speed up healing. And there's thousands of literature now, different cookie cutter companies. There's several big ones on the market that have research to back them up. But it accelerates wound healing because of all the different growth factors it provides for chronic wounds.
All right. And let's see, another question came in here. I'm using Aquaphor now. and not all of my patients like it. Are there benefits of StrataGRT to use instead of Aquaphor? Shanna or Dr. Banks?
So I will just remind you that Aquaphor has about 40% petrolatum. It is a 40% petrolatum-based product. It also has lanolin alcohol in it. So that is fat. And so I think that if you were to ask any wound care provider, probably those are not two products that they would use to treat wounds with. And so just a reminder that StrataGRT is 100% medical grade silicone. And once that product is applied, is providing that perfect environment for the wound to heal. It is beneficial because it can be used without a dressing or with a dressing. But without a dressing, you know, it's a twice a day application. That transparent film is going to form and it's not going to be messy like Aquaphor. So I think that if you'll just give StrataGRT a try, then you'll see that it proves superior, especially to Aquaphor.
Awesome. Thank you very much. So a couple questions here for me to answer. One of the most important questions is, well, how do I get a sample? At Stratpharma, we firm believers in firsthand experience with your patients. So we can actually provide full-size, full-course trials for you, your staff, and patients. If you can reach out to us directly, and we will also be following up to everybody who registered to make sure that not only you have the recording and the download of this presentation, the product information, but we will also reach out to see how we can go about getting product for that hands-on experience. So just in case, our email, you can send it to customerservice@us.stratpharma.com. And again, if you're registered, we will reach out as well, just in case. And then we have one last question here, which is, how can I prescribe StrataGRT for patients? And, you know, how do I get patient access? StrataGRT is a FDA registered medical device, and you can prescribe it just like any prescription product. Although specifically right now, for the most patient access, we have it directed to one of our specialty pharmacy partners. Right now, that is Highland Specialty Pharmacy. Again, we'll follow up with the direct details on that. This pharmacy is equipped to work with all patients of all budgets, all types of insurance or non-insurance to get the most access possible. So we can provide the follow-up information, but it is available and ready to prescribe right away, along with our 4 other prescription products. And so that's where we're out of time here. I wanted to thank everybody, thank HMP Global, thank our speakers for jumping on. This webinar is going to be archived and available for viewing online within the next week or so by visiting the Wound Care Learning Network website under webinars. And again, Stratpharma will be following up with everybody that registered as well. So thanks again to all of our attendees, our speakers, and we hope everybody enjoys the rest of their day and have a great weekend.